Hey, thank you very much. It's a real honor for me to be here. I'm here with my wife, and we've gotten the chance to spend 36 hours in Little Rock, and I've just fallen in love with the city. And I'm going to be rooting for Arkansas against Wofford and UNC and all the way. So I say, go Razorbacks. It's also really interesting and fun to be in Little Rock talking about healthcare and the politics of healthcare, because Arkansas is a very interesting state when it comes to healthcare politics, when it comes to the Affordable Care Act, and when it comes to thinking about the role of government in the healthcare system more generally. So what I want to do, if I can make this click, let's see how I do here. Oh, all right. Okay, I got it down now. What I want to do is do a couple of things in the time I have with you. One, I want to talk about a healthcare system in transition and the fact that, here in America and really around the world, the debate over what the healthcare system should look like is extraordinarily controversial, it's partisan, and it's incredibly important. Every one of us in this room, whether we work in the healthcare field, whether we're students in the healthcare field, or whether we're consumers of healthcare, every one of us is impacted by this debate on a daily basis. And what I want to do is talk first about the Patient Protection and Affordable Care Act, which was enacted, March, 5 years ago. I mean, it's almost a 5-year anniversary coming up in a week or so. And I want to talk about what the ACA says, what it does, what's happened, what's in the Supreme Court right now around the ACA. I want to talk a little about the politics and the substance of the ACA. But then I also want to talk about the fact that even if there was no Affordable Care Act, even if that law had not been enacted, the healthcare system in the United States is and would still be in the midst of an extraordinary change and extraordinary transformation. And I want to talk a little bit about that transformation that's being driven by markets. So actually you've got this interesting dynamic going on in which government and government policy is shaping to a large degree what's happening in the healthcare system. But independent and at the same time, various market forces are pushing. So there's this sort of combination of market forces and government sort of working, interacting, and I want to talk a little bit about that with you today. All right, the Affordable Care Act. Affordable Care Act. 3 main goals. I'm not going to spend a lot of time on this. Back in 2009, 2010, when the law was being debated and enacted, we had about 45, 50 million uninsured in the United States, another 20, 25 million underinsured. That 40, 45 million was at a moment in time, on any single day. Over the course of a year, there were probably 75, 80 million who lacked health insurance, because people churn on and off the rolls. One goal that President Obama had, one goal of the Democrats, one goal that President Bill Clinton had, in the early 1990s, was to provide significantly expanded health insurance for the uninsured. Containing the cost of health care, we spend almost $3 trillion a year on health care here in the United States, about 18% of our gross domestic product, over $8,500 per person on average here in the United States. Second goal of the ACA, try to get a handle on those costs. Third goal, try to do something about the delivery system. How do we deliver care here in the United States? How do we make that care delivery system more effective, more efficient, higher quality? Politics, we talk about politics. The debate over health care triggers all what I would call the 3 I's. Interest group dynamics, you got a $3 trillion industry, you got some big players, big interest groups. And I'll tell you one thing that everybody in this room knows, every doctor, every hospital official, every pharmaceutical company official, every nursing home owner, they would agree that the healthcare system needs fixing to a large degree, that the healthcare system has a lot of problems, a lot of issues. It may be one of the greatest healthcare systems in the world, but it needs fixing. But they would all, to a large degree, say it's the other guy, it's the insurance companies, or it's the pharmaceutical companies, or it's the hospitals, or it's the everybody sort of views themselves kind of as the hero of the story. So President Obama knew the interest group dynamics and fighting would be fierce, Ideology, we're a country that has fundamentally divided views over the role of government. And the debate over health care reform is largely a debate over the role of government and the relationship between government and markets. how the two work together, how the two don't work together, what should the federal government do, what should the states do, what should be left to the private sector. And President Obama and the Democrats knew very well that this proposal for a comprehensive, expanded piece of healthcare legislation would be very controversial, and about half the country would think it was a bad idea. And the other half of the country might think it's a good idea. So we were going to be split on that. And then the third I had to add a P in front of it, political institutions. We set up, back in the 18th century, we set up our government to make it hard to get major legislation through. We wanted limited government. You know, the president has limited powers. You know, he knew he was going to have to get 60 votes in the United States Senate to get something through. You know, he knew the courts would review. He knew the various committees in the House and the Senate. So we have a fragmented, decentralized government. All right. The politics of enactment was 5 years ago. I'd love to chat. I could spend hours talking about the politics of enactment, but I'm going to skip ahead at this point, just in the interest of time, to the politics really of implementation and what the law says. So let me start with coverage. The law says there are the ACA, the Patient Protection and Affordable Care Act, Obamacare, whatever you want to call it, has 5 basic ways it tries to help the uninsured. First, and what I'm going to do is sort of walk through what's happening in each one of these, and actually in almost every one of these, Arkansas has an interesting piece of the story to tell. The law required every state in the country to significantly expand their public insurance program for low-income populations known as Medicaid. The idea was about 15, 20 million Americans were going to get coverage from Medicaid that weren't previously covered. Lo and behold, the United States Supreme Court subsequently holds that that mandate, no good, unconstitutional, can't be enforced. So then we get a situation where that expansion of Medicaid, fully funded, at least for the first couple of years, by the federal government, but that expansion of Medicaid becomes optional for the states. Where are we today? 28 states plus DC have expanded their Medicaid program under the ACA, and about 7.5 million Americans have Medicaid today who didn't have it previously because of the ACA. 22 states have said no. And others are negotiating, and I'm telling you, when others are negotiating and others are thinking about it, many of them are looking to Arkansas, because Arkansas has expanded, and as probably everyone in this room knows, Arkansas not only has expanded, but they've done so in their own way. What they've said, what Arkansas has said, is we want to use those federal Medicaid dollars to get coverage for this expansion Medicaid population, but we're going to use those dollars to buy private coverage on the insurance exchange. So that so-called private option being implemented here in Arkansas, I gather, you would know better than I read the newspapers, very controversial, seem to be on the edge of not surviving, but has survived for at least a couple more years. And Iowa and Pennsylvania and many other states around the country are looking at that Arkansas model as perhaps a way that other states can say, you know what, we're going to do the Medicaid expansion, but we're going to do it our own way, the Arkansas way, the Indiana way, the Pennsylvania way, the Iowa way. And in fact, in 2017, the states will get even more flexibility under the ACA to shape expansions the way they want to shape them. My own guess is that long term, over the next 5-10 years, every state's going to adopt one version or another of a Medicaid expansion. But the key to in fact, Medicaid itself, just so you know, was enacted in 1965. It wasn't until 1982, 17 years later, that the last state joined the original Medicaid program. And that was Arizona. But my guess is every state's going to join this expansion too, but the 2016 presidential election is key. Because I think if the Republicans win the presidency and maintain control of the Congress, there's going to be an effort to cut back the Medicaid expansion, and some states that have not expanded are going to continue to hold off for a while. While if a Democrat becomes president and/or the Democrats take over one of the houses of Congress, then I think quickly you're going to see Texas and Florida and other states move into a Medicaid program, and they may well move in an Arkansas way. All right, that's one way. Second way the law tries to help the uninsured is the law says to every state, we want you to create a purchasing pool for uninsured folks, for self-employed folks, for small business folks, a purchasing pool so they can get lower cost private insurance. And in addition to that, we're going to subsidize the cost of that private insurance for families at 400% of the poverty level or below with federal money. That subsidy is, for family of four, 400% of poverty level, you're talking about $92,000 a year. So it's really middle class and upper middle class, perhaps, families that become eligible for those kind of subsidies. The initial expectation was that every state would create one of these purchasing pools, one of these insurance exchanges. For a variety of reasons that, again, we could talk about, 2/3 of the states said no. 2/3 said no, we're not going to form our own exchange. And in those states, the federal government said, all right, well, if you're not going to form an exchange, we're going to create one for you. And that's the backup plan that's in the law anyway. So the feds create a federal exchange that governs 34 states, then the rest of the states have their own state-based exchanges. I'm sure you remember the federal exchange didn't get off to the best start. January of 13, the website didn't work. In fact, some of the state-based exchanges, the Massachusetts, the Maryland, the Oregon websites, those states did it on their own. Theirs didn't work so well either. Big variation, but over time, about 11.5 million people have now gotten private health care coverage through those exchanges, either the federal exchange or the state exchanges around the country. About 85% of those people have gotten subsidies to help them pay for that private insurance from the federal government. There is now litigation underway, and the United States Supreme Court heard oral argument on that litigation on March 4th, just a couple weeks ago. And in that litigation, the challengers are claiming that if you buy private insurance through the federal exchange, i.e. 2/3 of the country, you're not eligible under the law for federal subsidies to pay for the cost of that health insurance. Only those, according to the challengers, who buy in the state exchanges are eligible for those subsidies. Now, I don't know how the court will rule. I know how I think the court will rule, but I don't know how the court will rule for sure. My guess is they'll probably uphold the federal government's position on this, but there's a chance that they won't. And there's a big question as to what happens if they don't. What happens to the people in those 34 states who are getting subsidized health insurance now, paid for in large part by the federal government, but who arguably will lose that coverage? Now, one option, and here's why Arkansas, again, is an interesting state. Arkansas has recently gotten money from the federal government because they're planning, right now, people here in Arkansas buy through the federal exchange, but Arkansas is moving to create their own state-based exchange and has federal money to help them do so in the next couple of years. So in theory, if the Supreme Court holds you only can get subsidies through the state-based exchange, some states who are in the federal exchange right now will follow the Arkansas model and will move into, create their own state exchange. Who knows? Who knows? One other issue I would just point out in terms of politics to keep your eye on over the next month has to do with the taxes. When people at the end of 2013 said, I want to buy through the private exchange, you had to estimate what your income for 2014 would be. And the lower your income, the more subsidized, the higher the subsidy would be that you would get. And you would get that subsidy paid for in advance. Now that people are filling out their taxes for the year 2014, if it turns out that they estimated their income too low, then maybe they got too high a subsidy, then now they may have to pay some of that money back to the federal government. If they turned out they estimated their income too high, then maybe their subsidy was too low, maybe they're eligible for a bigger refund from the federal government. But federal officials think a lot more people estimated low to get high subsidies than estimated high to get low subsidies. So there's a lot of people who could end up paying some money back to the federal government on April 15th who are not going to be particularly pleased about that, and there's a political story and tale there as well. Third thing, so one thing the law did is expand Medicaid coverage. Controversial, difficult implementation, big story. Second thing the law did was create these exchanges. Controversial, difficult implementation, big story. Third thing the law did is said every employer with 50 or more employees has to provide health insurance for their employees or else pay a penalty. Controversial, difficult implementation, who knows how it's going to play out. It's been delayed till January 15 for some firms over 100, till January 16 for firms between 50 and 100. The Republicans in Congress are suing the executive branch, saying they didn't have the authority to delay. This is another piece of litigation. On and on it goes. Fourth thing the law did to help the uninsured. Before the Affordable Care Act, before the ACA, it was basically the states that regulated the private insurance industry. The ACA, really for the first time, imposes a host of new regulations on the private industry. It tells private insurers you can't exclude people because of pre-existing conditions. You got to let kids up to the age of 26 stay on their parents' health insurance. You got to basically charge everybody the same regardless of their health status. You got to pay at least 80–85% of the premiums you take in. You got to pay on medical care, not on administrative fees. So there's all these new federal regulations that are in place. And they're in place now. Battles, regulatory battles, but they're in place. The insurance industry said, oh my gosh, you're going to impose all of these new regulations on us. How could we possibly survive? How could we possibly survive if we have to accept everybody regardless of their pre-existing condition? How could we possibly survive if we have to charge everybody almost the same rate? Well, that then gets you to the last piece. The fifth thing the law does is it says, you know what? Everybody in America has to have health insurance unless they either have a good excuse or else if they don't, they have to pay a penalty on their taxes. A relatively small penalty at first, but then that penalty ratchets up. The idea of the individual mandate was to try to encourage, to have a stick, to encourage, to require, to push relatively young, relatively healthy populations to get health insurance to help pay for the cost of covering the older, sicker, higher cost folks who the insurance companies also now have to cover. That so-called individual mandate was also challenged, as I'm sure all of you know, as being unconstitutional, and on a 5-4 vote with a very tricky decision, interesting decision in which John Roberts cast the deciding vote, the Supreme Court upheld the individual mandate. In 2014, there will be about 32 million Americans who will declare on their taxes that for more than 9 months in 2014 they didn't have health insurance. But only about 6 million of those are going to have to pay a penalty. The majority of the others will be exempted out for a variety of reasons that we could talk about if you want to know. So how this stick works and how it'll work going forward, big issue. But those are the 5 ways the law tries to help the uninsured. Medicaid expansion, state-based exchanges with the feds as the backup, or these private exchanges, these exchanges with federal subsidies, number 2, the employer mandate, the new federal regulations, and the individual mandate. 5 ways. The result is about 11 million people have private insurance that they didn't have before. About 5–6 million have Medicaid that they didn't have before. And there's still about 35 million uninsured. That number will go down, though, over time. All right. Let me switch to costs for a few minutes here. I don't have to tell anyone in this room that the United States spends a lot of money on health care. This is a couple of years ago, actually, almost 18%, over $8,200 per person. And you can compare that. What's interesting, if you actually look at the US on an international comparison in the year 1975, was that 40 years ago? You look 40 years ago, we're below Canada on average GDP, average per person, and we're below most of Europe. We actually, in the 60s and 70s, were not the outlier. But starting in the 70s, 80s, 90s, and on, our costs have gone way up, while others have maintained a more level pace. And now we lead the world by far. Question is why? You know, it's interesting. We spend so much more on healthcare than anybody else, but we actually go to the doctor less often than our peers in high-income countries around the world. We spend less time in the hospital, fewer days in the hospital. We take fewer pharmaceutical drugs. We're younger. Look at us. We're young. We're a young population. We smoke less. I mean, geez, you go to Europe, it's like, the smoking rates in other parts of the world are way higher than the United States, and our rates are coming down. So you say, well, gosh, if we're younger, we smoke less, we don't go to the doctor as much, we don't go to the hospital, we take fewer drugs, how in the heck can we spend so much more than anybody else? Well, there's a lot of theories about that. I'll give you sort of some basics on it, but there's a lot of theories. But one thing that is not debated is that the cost of anything, the cost of this clicker, how much America spends on clickers, how much we spend on podiums, how much we spend on chairs, the cost of a particular item is the price times the volume. What's the price of the item and how many of them are you buying? P times V. P times V equals cost. You can't really debate that too easily. All right. Turns out, I said a couple of minutes ago that the volume of our cost, or the volume of our services on doctor's visits is relatively low. But here's the kicker. The price we pay for everything. Now, we can have a long debate about why the price is so high, but the price we pay for everything in the United States is much higher than anyone else, and our volume of high-tech services is much higher than almost anybody else. So I just have this one example just to illustrate the point. MRI units per million population. US, Germany. The US, we have about 27 per million population. And we use them. We use them. Build them and use them. Germany has about 8. So we have more than 3 times as many MRI units as Germany. In addition to that, not only do we have more and use more MRI units, but the price we pay every time we use one of them is about 5 times as much as Germany. So we use a lot more of them, and every time we use them, we pay a lot more. And that $10.57 per procedure, here's why that's even a little deceptive, because that includes what Medicaid pays and what Medicare pays. If I just was going to show you what private insurance companies pay for MRIs, the number would be significantly higher than that. Significantly higher. So, big debates. Now, we could spend a whole hour or 2 or months talking about why the price is so much higher here and why our volume of certain services is higher here. But let me just say that when it came to dealing with this issue for the drafters of the Affordable Care Act, there were essentially 3 different kinds of options. 3 different kinds of options. Option A is we could do what much of the rest of the world does to contain costs, for better or for worse, and there's some pros and some cons. What the rest of the world does, what Germany does, what England does, what France does, again, good and bad, but what the rest of the world does is they regulate that price. Now, we regulate the price in our public programs like Medicaid and Medicare, but we certainly don't regulate the price in the private sector. We don't regulate what a private hospital could charge a private insurance company. That's a matter of negotiation. That's a matter of markets. That's a matter of leverage. Others regulate both price and volume. Other countries say, you know what? You can't have so many MRI machines. Or you can't have so many CAT scans. Or you can't have so many A, B, C, or D. So other countries regulate. We leave it to the market. And so some suggested that maybe the ACA or maybe Obama or maybe whomever should say, well, maybe we should regulate prices. Actually, there's one state. Does anybody know there's one state in the country that actually does regulate what hospitals can charge all payers? Maryland. And you know what? Maryland has had the lowest rate of increase in their hospital costs in the United States for each year over the last 20 years. And Maryland has, it's not Columbia, but Johns Hopkins, it's okay. I mean, it's not Arkansas, it's not UA, but it's okay. So it's possible. In fact, New York used to have what's known as an all-payer hospital reimbursement system. New Jersey did, a few states did. Most states have gotten rid of them. Maryland still has it. But nobody at the national level was even suggesting in 2009 that we move to some sort of regulatory system like that. Because the politics of that was simply unimaginable and would have derailed the entire ACA. I mean, the administration was already being accused, because remember, what was going on in 2009, 2010? Remember, the economy was in bad shape. The government was bailing out insurance companies, it was bailing out automobile companies, it was bailing out banks. There were arguments and allegations that that Obama was trying to take over the automobile industry, was trying to take over the healthcare industry, et cetera. There was talk of, sort of government bureaucrats getting in between, doctors and patients and death panels and on and on and on. And so so the thought that the ACA should include some sort of significant regulatory control on prices off the agenda. So that left two other options. And here's where the debate really took place. Option A, or B, if you get rid of the regulatory. Option B says, all right, you know what? Why are healthcare costs so high? Why are prices so high? Well, the reason prices are so high, say people in option B, is because patients, consumers, are immunized from the true cost of care. Somebody else is paying the bill. There's an insurance company paying the bill. You go into the hospital. I mean, if you're getting one of those MRIs, you don't know how much it costs. You don't care how much it costs because someone else is paying the bill. Now, in recent years, in the private sector, putting aside government for a minute, in the private sector, one of the biggest ways employers have been trying to deal with the rising cost to them of healthcare is by shifting more and more of the cost of healthcare, whether it's a share of the premiums or deductibles or copays or whatever, shifting more and more of the cost to the consumer, to the employee, to the patient. And so there's a lot of people that argued in 2009, there's a lot of people that argue in 2015, that if we want to get a handle on costs, what we need to do is give consumers, give patients more quote-unquote skin in the game. Get them to feel the cost of healthcare and they won't spend as much. In order to do that, the argument is you've really got to make healthcare costs more transparent. You got to let people know what the cost of hospital A, B, C, and D is, or doctor A, B, C, or D, what their quality ratings are. You need transparency in the system. There's no transparency, or I shouldn't say no. There's very little transparency in the system right now. People don't really know what the cost is. They don't really arguably care because they don't have a lot of the cost shifted onto them. So there's a lot of folks who said, you know what, let's try to, in the ACA, have language that will lead to more transparency and will lead to more consumer choice. And you know what, there's a big push these days in the field of economics, so-called behavioral economics. We want to use financial incentives to kind of nudge people in the right direction, to make the right kind of choices, quote unquote, the right kind of choices. So let's give people a financial incentive to be more cost conscious and more quality conscious. Let people buy health insurance across state lines. Let's have more high health savings accounts and high deductible, insurance policies. To a large degree, sort of this category P is, I think, category B is where you would find many sort of Republicans, sort of market-based folks. People think, what we really need to do is have more of a market-oriented system in which individuals feel the cost of care themselves, and that'll lead to lower costs. So that was option B. Option C is where the ACA really is. Option C is to say, you know what? What's the most expensive thing in the healthcare system? Let me ask you. Tests? Surgery, tests, long-term care, ER, the doctor's pen, all of these things. But why does surgery happen? Why do tests happen? Why does long-term care services happen? because a doctor orders, a doctor says, I'm writing the prescription. And so option C was to say, you know what? Historically, providers have been paid every time they did anything, regardless of outcomes, regardless of quality, regardless of anything. Let's actually try to give them a financial incentive, again, to be more cost conscious. And that effort, the effort to build in pay for performance, value-based purchasing, financial incentives, but to push those incentives onto the providers, that is at the heart of the ACA's effort to help the uninsured. ACO, accountable care organizations, bundling, there's all sorts of ways. I'm not going to, just because we're down to my last 7 minutes or so, I'm not going to sort of, walk you through all the ways the ACA tries to do this. But not only does the ACA try to do this, but this is happening in the market also. This is happening in the market also. All right. Now, the last 3 or 4 years, now when I say health, it's the rise in healthcare costs that's slowing. Costs are still rising. Healthcare costs never go down. But they're going up at a much lower rate than they had been. And so there's a fierce debate as to why. Well, there's two kinds of debates. There's a debate, number one, over why, and number two, is this long-term? Is this like a short-term 3-4 year blip, and 5 years from now costs are going to be shooting up again? Or has something fundamental changed? So why have costs slowed? Well, the administration would say, well, what do you think? If the ACA gets blamed for everything else, we might as well take some credit for, the more slowly rising healthcare costs, but I don't know, probably not the case, especially since the ACA wasn't even really implemented. It was enacted in 10, but it wasn't implemented until 2014. We could talk about why the 4-year delay in implementation, why the law took 4 years to actually implement, but that's another question. Maybe it was the recession. There was a recession. As I said, costs have been shifted more to the individuals. Maybe people are not spending as much out of pocket. Maybe that's it. The pharmaceutical industry, the Pfizers and the Glaxos and the Sanofis, people may have said, oh my gosh, pharma makes so much money, has such huge profits 10 years ago. But these days, it's a much tougher industry for pharma now. There's a lot more generics. There's no new big Lipitors. You don't have every guy over the age of 40. Now they're on a generic. They're not on a Lipitor, whatever. So maybe it's the absence of blockbuster drugs. Maybe the system's become more efficient. But also, there are things happening in the market. And what I want to do now is, I don't know if David Letterman's popular here and the guy's going off the air in a few days, but, well, not a few days, a few months. But, he always has his top 10 list. So what I'm going to do is give you my own, what I like to do, if we had more time, I would like to ask you what you think the key trends are in the healthcare system today, and then we can compare lists. But since we don't have time for both you and me to do it, I'm just going to give you mine, and then we could talk about it. But here's my list as to the top 10 trends going on in the healthcare marketplace today. In the marketplace, many of which are encouraged by the ACA, but that are happening independent, even if Mitt Romney had been elected president and the Republicans were in Congress, and on the first day of the Romney administration, somehow the ACA disappeared, everything here would still be happening, I think. Number one, the system is becoming more and more and more consolidated. There are fewer and fewer and fewer solo practice docs, and they're going to be a disappearing breed. Even in rural Arkansas, it's going to be extremely difficult to have your own solo practice office. The demands in terms of electronic medical records and more, the demands are just too financially tough. And you can't survive unless you're part of a system these days. There's a consolidation. Hospitals are consolidating. Hospitals are buying physicians' office. Everybody's trying to get bigger. And why do you want to get bigger? Efficiency and volume. There's a reason you guys are in the front row. That was good. That was right. So efficiency and volume. Now the efficiency, we don't know how well that works out, but the volume, we know that name of the game is leverage. Name of the game is leverage. The bigger you are, the more leverage you have, and that helps when you're negotiating. Number two, not only is the industry consolidating, but it's integrating. And what I mean by integrating here is the lines are blurring. What has historically been a very siloed healthcare system, the hospital, the doctor, the pharma company, the insurance company, the this, the that, the other thing, those lines are blurring. Hospitals are buying insurance companies and going into the insurance market. Insurance companies are building provider offices. The lines are blurring. Everybody says we want soup to nuts. We want to have a big system in which we've got the whole soup to nuts. You know, you start out with your primary care physician, your lab, your hospital, your nursing home, birth to death, one system, integrating. Third, there's all sorts of new players. Now, I don't know, is CVS big in Arkansas? I don't know if there's much CVS here. Excuse me?
5 stores and 15 coming.
All right, 5 stores and 15 coming. CVS wants to be 10 years from now, they want to be one of the biggest healthcare players in America. Walmart. Now, Walmart, you can't tell me there's only, I know Arkansas a little. I know Arkansas, and, Walmart wants to be, they want to go into the healthcare business. Walgreens, these big companies have become sort of the general stores of America. And the CVSs and the Walgreens and the Walmarts, they want to have, in addition to the pharmacy, they want to have, whether they call it a minute clinic, which is what CVS calls it, or whether they call it sort of a small little healthcare, primary care clinic, and that clinic will have relationships and connections with other healthcare providers. Urgent care. Again, I don't know, has urgent care hit Arkansas? All right. In Manhattan, I could tell you, 10 years ago, they didn't exist. Now you can't walk down the streets of Manhattan without passing 3 urgent care facilities. And that's a fact. No, just not exactly. But so there's all sorts of new players, and what that means is there's confusion about who does what. CVS wants to be a healthcare player. What's a hospital? I mean, if you sat and talked to the CEO of a pharma company or the CEO of a hospital, and you said to them, what is your institution going to look like in 10 years? What's the job of the CEO of a pharma company going to be? It's going to be very different from the job of a CEO of a hospital or a pharma company today. Narrow networks and high deductibles. I'm sure everyone in this room is feeling this a little bit. The networks of providers you have available to you are narrowing, and your share of the cost is rising. Number 5, value. I mean, if there's 3 big words if you want to walk out of here with like the 3 biggest buzzwords in healthcare, one of them is value-based purchasing, value-based reimbursement. Nobody quite knows how to do it. We don't really know how to pay for quality in healthcare because it's very hard to define quality. It's very hard to measure it. How can you tell if the outcome is really better just because of what the doctor or the hospital did, or et cetera? But we want to move to metrics to paying for quality. We want to focus more on care management. And I love this because years ago in the late 90s, we had the so-called managed care revolution in America. And managed care, nobody liked. But you flip the words, everybody likes care management. I'm telling you, it's framing. It's all about framing. More engaged employers, I'm almost done. I'm down to my last 2 minutes. More engaged employers. There is not a Fortune 500, Fortune 1000, Fortune 2000 company in America right now that doesn't have something they're calling an employee wellness program. What's the return on investment of those? How are they working? Are they really improving employee health? Are they giving a return on investment? Are they PR for the company? I mean, we don't know, but clearly that's a trend. I'm in a school of public health. This may be our day. Population health management, again, everybody's talking about it. Providers and others saying, how do we care for the health of a whole population, a city, a community? That's very big these days. Comparative effectiveness. What's comparative effectiveness? Anybody know? Cost versus benefit. Cost-benefit analysis. Now, we think of it around drugs. We think, my gosh, this drug is going to cost 10 grand more. This drug is going to cost 50 grand more. But it's going to add 3 more months of life or 4 more months of life. Well, or this drug's going to cost 200,000 more and add 6 months. Or, how do we measure in healthcare? How do we balance? Do we just pay for everything? Well, historically, we haven't liked comparative effectiveness in the United States. We don't like it. It sounds like rationing. It sounds like, my gosh, the rich will get it because they can pay that extra money. But what about us? We're going to die 6 months earlier. So we have to think about but I'll tell you something. Every insurance company, every payer, they're thinking about, well, how do we balance the costs versus the benefits of, and it's not just of drugs, of everything. And last but not least, you can't do any of these other things I'm talking about. You can't consolidate, you can't integrate, you can't do value-based reimbursement, you can't do care management, you can't do any of it unless you have greater use of health information technology. And there's a major, major, major effort these days to build up HIT. So the bottom line is, in terms of the ACA, the debate continues. Yesterday, on the same day, just a day after the brackets for the NCAA were revealed, I was mainly reading that. But in the corner, I saw, federal officials claim 16, 17 million helped by the ACA. 16, 17 million have health insurance who didn't have it before. And and in the other corner, underneath, the Butler line, the Butler announcement of their game was, House Republican, vote again to repeal the ACA, to convert Medicaid into a block grant, to change Medicare fundamentally. So the debate over the healthcare system remains fierce. It remains fierce, it remains partisan, it remains controversial. There's nothing more important to the health of the nation than the kind of healthcare system that we have. In my view, the ACA has significantly increased access for uninsured folks, but it's really the market-based efforts that are significantly changing the delivery system right now. How those two things meet is a really interesting story, and it's going to be an incredibly important story, and where the nation is looking in large degree for answers to that story is right here in Little Rock and right here in Arkansas in a whole host of ways. So it's really an honor for me, it's a real honor for me to be in the Clinton School of Public Service giving a talk. I could not have more respect for President Clinton and the kind of work that he did. So to be here, to have a chance to tour the library earlier today, it's a real honor, and I'd be happy to try to answer any questions that you might have. Thank you.
Well, that was a fascinating. I learned more about the Affordable Care Act and the state of health care in America today than I have in a long time. I wish members of state legislators and Congress and everybody else could see that presentation. It's very good. We have lots of questions, so let's start right back here.
Thank you. That was an excellent presentation.
Thank you.
And as far as the ACA, it's been good for Arkansas. I led the 35-member grassroots group that helped pass it. We're trying to defend it. We cut our uninsured rate in half, led the nation, but it hasn't been easy. And the politics of this, and thinking about the RS slides that you put up there, I think Obama's probably played fast and loose with the law and all these extensions and postponements, but I am going to be surprised if they let these tax penalties hit here next month. I'm going to be more surprised if the higher penalties hit in the spring of 2016 in the middle of the presidential election. So what are the odds that somehow through regulatory stroke of the pen, the tax penalties go away? I think they're pretty good. I wondered if you...
Sure. No, it's a great question, and that's one of the reasons I highlighted that, because with April 15th coming, there's a lot of nervousness in D.C. because in fact, there's sort of, not only do you have 6 million people who may be paying, penalties, not only do you have many millions who may have to pay back, subsidies because their income was higher than expected, but you also have people having to hire, having to go to, H&R Block now, or because their tax returns are a little more complicated in terms of how they demonstrate this income. So there's a very politically sensitive area. I think with the flick of the pen, they're not going to get rid of, the law itself, obviously, but I think there's going to be an effort to sort of, as you point out, to minimize the adverse consequences. And I would agree completely. I would not be at all surprised if there aren't additional waivers that are given, if there aren't additional sort of efforts to basically say, right, so there's, Well, that's why even if you look at the numbers of the 32, 33 million who in theory are, will be uninsured for more than 9 months during the year, there are estimates now maybe somewhere between 5 and 6 million will actually pay a penalty. And that penalty for most of them would be $95. So you're not talking about a huge, huge financial penalty, but you add $95 up with a slightly higher tax, a bill to your tax preparer, added to maybe some having to return some subsidies, then you're talking about money, and you're talking about money for sort of low-wage, middle-class folks. And so I think I would agree with your prediction there.
I have a comment and a question. My comment is, I wish you'd reframe your statement that we have the best healthcare system in the world to say we have the best technology in the world, because we are approximately 25th in the world in health outcomes, below some second tier countries. You can't say we have the best healthcare system if we have health outcomes like that. My question is, do you think we will ever have the guts to adopt a single-payer system?
Sure. Those are both great. It's a great comment and a great question. The cross-national comparison issue is fraught with problems on all sides. And I think the rankings that come out, whether they're by the Commonwealth Fund or by the WHO or whoever, are problematic in one way, in many, many ways. For example, everybody defines primary care differently. So, how we define how many primary care docs we have versus other countries really varies. There's no question in certain areas, if you have certain, and it's not just technology, if you have certain kinds of cancer, there's probably no place you'd rather be in the world than some of the cancer centers here in the United States having that cancer taken care of. On the other hand, our rates of infant mortality, our rates of low birth weight babies, our rates of our lifespan more generally are significantly lower than other countries. And this is something we've been working on for a long time. In fact, I think I have this right, but I think when Bill Clinton was governor of Arkansas and Hillary Clinton was the first lady of Arkansas, the two big issues, for Southern governors at that time were trying to improve the public education system here in Arkansas in the South and trying to reduce rates of infant mortality and low birth weight babies in the South. And that led to expansions in Medicaid coverage, et cetera, et cetera. In terms of your comment on single payer, no. Okay.
That was a definitive answer.
But that said, here's what I do think is going to happen. I think over time, and this is just, I don't know if this is going to happen, but I think over time, the Medicaid expansion, and I think Arkansas is leading this in a way, but the Medicaid expansion and the exchanges, I think are going to blend into one, merge into one. And so instead of having 68 million on Medicaid and 5 million on CHIP and and X numbers in the exchanges, all those people are going to be in sort of one system. And then when you throw in the 45 million on Medicare, we actually, while we don't, we actually will have a larger public insurance system than private insurance system. And the last thing I'd say on that is no country in the world has what you would call a pure single-payer system. The difference between the United States and other countries is many, not all, but many other countries have a public system that provides sort of a minimum level of coverage for all, and then the private system provides sort of supplementary benefits, for others on top of that, just like the way Medicare hardly provides a full benefit package for people, and most people have to get supplementary coverage. In the United States, we're really the only country that has a for-profit insurance company as sort of the mainstream system, and then the public coverage on top of that. So I think, but every country in the world, I think, has this mix of public and private. We're never going to go as far for both ideological reasons, political reasons, and just the fact that the system is so entrenched at this point as to a classic single payer, but the lines will get increasingly blurred.
Really enjoyed your points about the market forces that are shaping a lot of things. It does seem, though, that monopoly that exists in so many places, particularly in this state, really limits the ability of those market forces to be effective at reducing costs. What do you think the future holds there?
Clearly, and again, I'm not an expert at all on the Arkansas sort of market, and one of the things that I think is true about healthcare, one of the adages about healthcare that's true is healthcare truly is a local, market. And so the healthcare market in Little Rock and Arkansas in the South, et cetera, is very different from the healthcare market, say, in the Bronx or Manhattan. I think there's also a lot of evidence that consolidation doesn't lead to lower costs, it can lead to higher costs, and I think, and so, I think as the system consolidates, you're going to see potentially higher costs, but then the question, where it gets really blurry then is when both the providers and the payers when they become one, then it's really uncertain as to how it's going to play out. And again, the role of government there and the role of the private sector, at a certain point, we won't have a monopoly. In fact, if we had a monopoly, then we'd arguably have a single payer system, either if it was a government monopoly or a, one big private monopoly. But, I think what you're going to see is probably in each region of the country, and this is just a guess, because, a handful. Now, a handful in some states and communities, maybe 3, and a handful in other places, maybe 8. But you're going to see 3 or 8 somewhere in between sort of big systems. And how that plays out, I just don't think we know at this point.
I have a question about the odds of the government regulating healthcare prices, but it seems like for a lot of us who have private health insurance, the health insurance companies, in a sense, regulate the prices that they're going to pay to the provider. And so many times you get a bill from your doctor or your MRI, and it says they charge the insurance $1,200, but the insurance just says, no, we're not going to pay that. We're going to pay $500.
Right.
Who are the providers actually getting these $1,200 from? Because it seems like if you have private insurance, the insurance regulates it, and if you don't and you're poor,
Right.
you end up not having to pay it in the long run, or you get a write-off. But who is actually paying these higher prices?
Who's behind that curtain? They're behind that curtain. I don't know how many of you read a couple of years ago. Stephen Brill had the longest article ever in Time magazine, and it was on the so-called charge masters that hospitals have. Hospitals have this kind of list of charges. Every hospital has one. This list of charges in theory for every service that they provide, and the charges there. Nobody pay. The only people who pay those charges are like the Saudi Arabian princes who come to New York for certain kind of services, and maybe are in the concierge floor of New York Presbyterian. They may pay those charges. But those charges then get used by the hospitals as a two things. Number one, they get used as a way of negotiating with the insurance companies. Well, our charge is $1,000. You want to pay $200. Let's settle on $500. They also become a way of sort of charging the uninsured, even though they don't expect the uninsured to pay. But even though they could then sell the bill to a collection firm, and then the collection firm will go after the uninsured person, and they could sort of write it off as bad debt. But the actual price then becomes purely a matter of negotiation. How much leverage does the University of Arkansas medical system have? How many insurance companies are there here? And do those insurance companies, if they need the University of Arkansas, medical system in their network, then the University of Arkansas, medical system has a lot more leverage when it comes to negotiating with whoever the insurance company is. If they don't need them as well, then, so there's a lot of, it comes down to market forces at that point.
Right here.
Thank you. Sorry. I'm taking a course at the Med Center called Racial and Ethnic Health Disparities. Mm-hmm. And we've learned some about the effects that pay for performance may have on the uninsured and other minorities. And I wondered if you could speak to that.
So in terms of, there's no question there's all sorts of health disparities in the United States based, the numbers around whether it's racial, ethnic, or sort of low-income rural white areas that are uninsured are just much higher than any others. And I think there's no question that when it comes to the uninsured, the ACA has gone a long way toward reducing some of those disparities in terms of uninsured, in terms of the number of people who have insurance. Then question is, what does that insurance card get you? And do you have access to a decent healthcare provider, a decent quality system, et cetera, et cetera, et cetera? In terms of pay for performance and disparities, I think one of the areas where, and I'm not sure what you have in mind, I know one of the areas that has triggered a fair amount of discussion is one of the efforts I talked about using incentives to encourage hospitals to be more efficient. One of the efforts is to say, the federal government now says, hospitals, if the rates of readmission to your hospital within 30 days are higher than we think they should be. In other words, if somebody comes in for heart surgery or comes in with pneumonia and they're discharged, generally speaking, if they show up again in 10 days, the hospital, in theory, gets to charge a whole nother visit for them. So now the federal government's saying, if your rates of readmission are higher than we think they should be, you're going to have to pay a financial penalty. And a lot of hospitals that treat primarily low-income, underserved populations have higher rates of patients who show back up at the hospital within 30 days for all sorts of reasons. Maybe they're sicker, or maybe they don't have language skills, or maybe they don't have care management skills, or maybe they're not taking their medications, as well as they should. Whatever it is, they show back up, they show up more often. And I think there's no question that a lot of the so-called safety net hospitals will argue that in a system that looks simply at readmissions or criteria like that, they're going to be hurt more than sort of systems that treat sort of higher income, middle and upper middle class folks. But was there something in particular that you were thinking that you heard about in class that? No, I think that. Okay, great, thanks.
What's the role for the health savings accounts in the ACA?
So I think again when I was talking about sort of there were different ways to get at healthcare costs. There's no question that those who believe that higher costs are due and higher prices are due to consumers and patients not having financial incentives believe we should have more health savings accounts. And in the private market, even independent of the ACA, there's been growing use by employers of ACAs and other high deductible policy. HCAs, are coupled with a high deductible health insurance plan, and that is increasingly becoming a financial tool in terms of sort of long-term retirement savings, even for some. In terms of the ACA, for certain young folks, on the exchange, you do have access to, first of all, the deductibles, in general, the deductibles on the exchange are high. They're, and as many of you know, there's different kinds of policies you can buy on the exchange. There's a bronze, there's a silver, there's a platinum, there's a gold, there's this, and then depending on who you are and depending on what's offered in your region, you do have access, to some HCAs. But the HCAs in general are not a part of I don't think they're really part of the ACA. Go ahead. Why? I think why? Because the drafters of the ACA were more of the opinion that the way to get a handle on costs was by imposing pressure on providers than by imposing fiscal pressure on individuals. They said a lot of the pressure on individuals is already happening in the marketplace. Employers and others are shifting, and there are these high deductibles. But I think, that's where you saw a little bit of a split, whether it's between Republicans and Democrats or liberals, and, whatever you want to call it, between those who said, the argument against HSAs, that many would posit is that with high deductible plans, maybe people will deter care, but maybe they'll deter care that they really should be getting. So I think there was a pushback. There is pushback against the HCA model by some. And I think it was not viewed as there's lots of, the ACA is a huge bill, a couple thousand pages, et cetera. But if this was a room of all physicians, the first 7 questions that would have been asked were, well, what about medical malpractice? And why is there not a major effort to deal with the high cost of medical malpractice and so on? So, I think, the ACA, while it does a lot, doesn't sort of deal with every issue, and it doesn't incorporate fully every policy option that's out there, and there were choices made, and the choice was made more to deal with incentives on providers than incentives on consumers.
I know there are a lot of questions. You can see your hands, but we've run out of time and people have to get back to work, I know, but Michael's going to be here for a while, so please come up and visit with him. This is really an engaging conversation. There's been as much interest from the audience as any program we've had, and I got to give a special shout out. Thank you for coming. I got to give a special shout out to the person who suggested this program to us, one Chelsea Clinton, who said, this is the person you ought to bring to speak about this issue. So Chelsea, wherever you are, thank you. And Michael, thank you very much.
Thank you.